Yes, madam, please. Thank you.
Thank you. Good morning. And thank you, organizers, for the invitation. Just like the previous speaker, I have grown up in this city, so this brings a lot of nostalgic memories. The one thing that struck me yesterday when I entered Bhavnagar, we've left the place long ago, is that it has changed. And what is important is change is constant, change is inevitable, and probably we should also think about changing our approach. Rather than keeping genetic testing at the bottom of the pyramid, either you do it along with baseline investigations, and in some cases, like if you're suspecting Morquio syndrome, rather than doing two enzymes, you can probably start with a genetic test. If you have a clear cut pathogenic variant, you don't need to follow it up with an enzyme assay. But what is most important is the right time. Even now, it is the obstetrician who refers couples who have lost children and they're planning another pregnancy. The missing link somehow still seems to be the pediatrician. It is impossible to counsel a family to reduce their guilt, and they carry the burden of it all throughout their life if their previous child had Dravet syndrome because of SCN1A mutation and you never tested the child. I will never know because I missed the most important sample. It is understandable when the child is sick, when you feel that the prognosis is poor, it is very difficult to explain to them to do another test where most probably you're not going to change treatment. And this is the most So the biggest argument that most pediatricians have is what's in a name? Why do we need a diagnosis? You don't have cure. For anyone who has a doubt, I've put this website. It's about a Swedish couple who lost three children to an undiagnosed rare disorder. I had a chance to meet the mother, and the one regret that she has is I will die never knowing whether I could have done anything else for them. So that name is important, not only for the family, it's not always treatment. Sometimes you're able to make that important decision to take away care. You don't need to have such moribund children staying on for a long time. It is an additional burden. So even absolving care, taking off care is taken as a good step in management, especially when the child is in an NICU. So when you talk about genetic tests, we commonly divide it into two different spectrums. One is the chromosome, and then is your DNA or the gene, and the gene is made of letters. What is important is now we have a unified method to look at both of these. But traditionally, what is the approach? If you look at karyotype, it's looking at large abnormalities, mainly your chromosomal aneuploidies. If you want to look at the chromosomes in more detail, you do a microarray. So if you're suspecting William or you're suspecting Di George, most of the times you would probably order a microarray. Then what about fish? Is it obsolete? It is the best assay to detect mosaicism. For anyone who is suspecting Turner syndrome or any sex chromosomal abnormality, because that is where mosaicism is very common, meaning that you will have two types of cell lines, one which is monosomy X and one which can have triple X, or you can have two X's, or you can have XXY. So whenever you're suspecting any Turner syndrome, please order a fish. It will tell you whether it is a full-blown Turner. It will tell you if it is a mosaic Turner. It will also tell you whether there is a Y chromosome, which if present, leads to a risk of gonadoblastoma. It's also mainly used for hematological malignancies, but that's out of scope. So basically, fish is only has minimal use for pediatricians. You're only going to use it when you're thinking of sex chromosomal abnormalities. So this is a host of photographs, and this is usually a pediatrician's nightmare. I see a dysmorphic child. I really don't know what is the syndrome, so what do I order? The first picture is actually multiple patients with Williams syndrome, but you can see that as you go down, the more bigger they grow, it's very difficult to catch the dysmorphism. The rest are all different syndromes. And the last one there is not Downs. he has hypotonia, he has polymicrogyria, he has seizures, so he's actually Zellweger. So what do? We usually get calls asking whether we should do microarray, whether we should do karyotype, or whether we should do exome sequencing. Doing sequential testing. Do one test. If it is negative, then you tell the patient to do another test. That's not possible. Sorry. It's financially more draining and the patient acceptance rate is very low. Probably you do one test, it's negative, they're going to change the doctor itself. So better than that is to do exome sequencing. So what is exome sequencing? When you look at a gene, you have multiple portions of the gene. The light blue is called the promoter, from where you start the translation. The dark blue boxes are called exons, which are the protein content of the gene, and the introns are the supporting structures. Now, 80% of disease mutations are present in the exon, and this is what we study in exome sequencing. So we mainly look at the exon and we look at small portions of the intron. As your test technology improves, we keep on looking deeper and deeper into the intron. There is no point of doing a clinical exome. Thank you. There is no point of doing a clinical exome if you have an undiagnosed disorder. An undiagnosed disorder means you do not have a clinical diagnosis. So we really don't know what we are dealing with. Today, I know the function of 6,000 genes out of 20,000 genes. Every month, new genes are added in the list. If you do a clinical exome, you're only going to sequence the number of genes that I know today. Tomorrow, if there is something new, I cannot find it out in my data. So clinical exome is an obsolete test. It somehow seems to have gained a lot of traction in the market. The price difference between a clinical exome and whole exome is minimal. So please order an exome sequencing. In fact, in the Western world, they have shifted to whole genome, which looks at both exons, introns, promoter, and the 3' tail region. But genome in India is still very expensive. It costs somewhere around 80,000 to 1.5 lakhs. It's easy to give out a page full of variants. It is more difficult to limit your report to the variants which are most important. So we have suddenly started seeing a lot of reports where there are pages and pages of variants given. And the patient says, now you interpret the test. It is not possible. So it is not only the test, it is important to see who is sitting behind to interpret your test. Your detection rate of exome is only 40 to 60% even now in the best times. Of course, it depends why you are doing the test. So coming back to dysmorphism, the simple message that I want to give is any dysmorphic child, whether you know the diagnosis or not, except for Down syndrome or Turner probably, you can use exome sequencing as a first tier test. There is no need to do a microarray. The current exome sequencing includes detection of copy number variants. We in our lab have run more than 1,000 samples, both between exome and array, and there is nothing that the exome has missed. It has picked up better than array. The array can only pick up large changes. The exome can pick up smaller changes. So there is absolutely no role of microarray, especially in the pediatric practice. There is still some role in obstetric practice, but there's absolutely no role in pediatric practice. When you're doing an exome, the more important question to ask is whether you should only test the child or you should do the child plus parents, which we call as trio exome. Trio exome is very important for neurological disorders. Many mutations, or rather variants, are occurring for the first time in the child. There is no change in the parents. We will never know that if you do not submit the parental sampling. Of course, it's slightly costlier, a single test versus 3 tests. So what is not covered within the exome? For those who want it, you can actually take a photograph of this child, this slide. The list is not exhaustive, but I have tried to cover the most common conditions in your clinical practice. Spinal muscular atrophy, you need an SMA MLPA. It will pick up 96% of your cases. Prader-Willi syndrome, a floppy infant who is having feeding difficulties. please do a Prader-Willi MS-MLPA along with your exome sequencing. If the MS-MLPA is negative, it rules out Prader-Willi by 99%. Congenital myotonic dystrophy. You just have to look at the mother. You do an EMG, you will get a dive bomber phenomenon. If you have to test the child, it requires a different technology. DMD, any child with an elevated CPK, male, you will first start with a DMD. MLPA for the neonatologist, difficult to wean child from a ventilator, recurrent apnea, the congenital hypoventilation or HADAD. You first need to do a FOX2B repeat expansion. If it is negative, only then you go to exome. Hemophilia factor level is very important, less than 1%. Severe hemophilia, you have to do an intron 22 inversion. Fragile X, any autistic child, male or female. Females also manifest Fragile X. Do a Fragile X PCR, mention the gender of the child. The kit that is used is different for females and different for males. If you do not mention the gender in your form, then it is possible that we will miss out a female. Congenital adrenal hyperplasia because of CYP21A2, the most common that you pick up on a newborn sequencing. It was not covered on a routine exome because the gene is complicated. You have to do a CAH specific NGS. Friedreich's ataxia, mitochondrial disease. Nowadays, most laboratories, including ours, covers mitochondrial sequencing within exome sequencing. But this is a list, and of course, there are many more, but these are the common conditions that you're going to come across where the exome sequencing will not help. Like the last speaker said, if you have multiple abscesses, one of the diseases that you think is chronic granulomatous disease. The most common mutation cannot be picked up by exome sequencing. You need a different test. So there is a caveat. You cannot just write off an exome sequencing. Coming to the right patient, I follow this checklist very strictly in my practice. Is the condition genetic? You have two children in front of you, oculocutaneous albinism versus vitiligo. We've started getting a lot of these reference, vitiligo, celiac, family history of ankylosing spondylitis. All of them do not have monogenic causes. Don't do an exome, you will not get anything. How well is the genetic basis described? So if you have a child with thalassemia major, of course, the chances that test will come out to be positive is much, much higher than if you have a child with autism. And this is important information to be conveyed to the patient during a pre-test counseling. Any child with a non-syndromic autism, chances that your exome sequencing will give you an answer is somewhere around 5 to 10%, not more than that. If there is a genetic basis in your clinical diagnosis, will it be detected by exome? For spinal muscular atrophy, do not order an NGS. Please do an MLPA. What are the chances of a negative result and what do they mean? There is a lot of talk saying that phenotype is gradually going to die. I don't believe that. So you have a family where the child has or a fetus had a cardiac rhabdoma and the father has typical skin lesions of tuberous sclerosis, you can still get a negative genetic test. It is known in 2% of cases. That does not mean that your clinical diagnosis is wrong. So there is no replacement to doing a clinical diagnosis. Everything has to go hand in hand. I just want to touch upon one case, cerebral palsy, HIE, which is probably the commonest in every pediatric practice. A lot of children still die. A lot of families still want to plan a pregnancy. And most of the times when we ask them, and I really am out of touch, but when I look at most of the notes, there's not much to tell us how severe was the birth insult, whether we can truly label what happened to HIE. So there was this family who approached us during the second pregnancy purely because the scan had some bilateral choroid plexus cyst. That is a finding which I would ignore. It has got nothing to do with cerebral palsy. But when we pulled out a history, we found out that they had one child who was suspected to have cerebral palsy. Her MRI was very, very suggestive, cystic encephalomalacic changes. She did not cry at birth. She had a stormy neonatal period. So they wanted to check the amniotic fluid. just to ensure that the second child is all right. It doesn't make sense. The question that they are asking is that they have an affected child, whether the same condition will recur. So you need to check the affected child, not the fetus. So when we did the exome sequencing, and we ourselves had told them that though monogenic causes are known in 11 to 20% or 40% of cases, we are not very sure because she did have a good history. What we found out was a homozygous pathogenic variant in cerebrotendinous xanthomatosis. She didn't have diarrhea. She did not have failure to thrive. She had, of course, not yet developed cataracts. So now what do you do? Cerebrotendinous xanthomatosis is a CP mimic. And this is what we need to open our minds to. There are multiple phenotypes which are not documented in literature. Literature only documents typical scenarios. We have to think out of the box. I will not say that it is possible that both disorders, both the cerebrotendinous xanthomatosis as well as her birth insight, probably contributed to her phenotype. But now I have a condition which is treatable and which to some extent can explain her disorder. And more importantly, I can offer them a prenatal test. So remember, and I've had this discussion with her treating neurologist, and he absolutely told me that this does not match. The important thing is genetics has come to a stage where you are going to get a lot of diagnosis which probably does not match your typical phenotype. Do not ignore them, especially if your variant is pathogenic. The guidelines for variant classification are very, 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 very strict. But if something is pathogenic, means there is so much evidence that it cannot be wrong. Of course, you need to know who is classifying the variant. If it's a software tool, it can be wrong. There are multiple platforms which classify the variants and give, they mostly over classify. And that is why it is important when you send a test to a lab, develop a relationship with the patient, with the person who is reporting, judge their knowledge, develop a comfort so that you can talk, you can discuss about reports. Otherwise, you might go wrong. So when you do a genetic investigation in cerebral palsy, there are 11 to 40% of cases which are because of monogenetic conditions, and they should not be missed because they might land up with another child. And more importantly, you might miss a treatable cause. When you do a test, you are also required to interpret it to some extent. So I'm just touching a little bit about interpretation. So this is a report for a child who died because of seizures. So this report says a heterozygous likely pathogenic. So in our language, pathogenic means that there is a 99% chance that that specific change has led to disease. Likely pathogenic means there is a 90% chance. Is the genetic diagnosis confirmed? Every letter on your report is important. Heterozygous and autosomal recessive do not go together. Heterozygous means there is only one copy which is having a change. For an autosomal recessive disorder, both copies should have the change. If the change is same, it is called homozygous. If the change is different, it is called compound heterozygous. So when you look at reports, please again reach out if you have any confusion. It is wrong to label a patient to have a disorder when they do not have one. So this is heterozygous likely pathogenic, meaning that molecularly we have not yet confirmed the disorder. The other change might be lying deep inside where the test technology did not go, or the patient might have a totally different disorder. This is the last case. This was a child who had recurrent fever, lymphadenopathy, lymphopenia, suspected primary immunodeficiency. They did a test in a lab where there was a homozygous variant of uncertain significance in immunodeficiency. Everything matched. So they went ahead, planned a pregnancy, they underwent a prenatal testing, and they delivered another child. The testing had shown them that this fetus should be unaffected. This child again developed recurrent fever, diarrhea, fungal infection, lymphopenia. We ran a test in our lab, and there was another variant in an immunodeficiency gene, which was likely pathogenic. A variant is important only till you find a better one. So this we had found the diagnosis after the birth of an affected child. So these are my take-home messages. A variant of uncertain significance is expected in all exomes. The diagnostic ability is 40 to 50%. A negative test will not exclude a genetic disorder. There is no single genetic test which will cover all genetic variations, not even thalassemia. Pre and post test counseling is important. It is difficult for us to form a relationship with the patient if you directly send them with a report, but natural, we need to look at them before you test. Consider genetic testing with other baseline testing. Baseline metabolic, immunological, radiological workup is still important. Do not give it up. This is a test that we do in our lab. It's an exome sequencing, which includes mitochondrial genome sequencing and copy number variation calling, including aneuploidies and smaller level deletions and duplications. You can contact me for any questions, and these are my contact details. You can contact me for any patient with any query. Just remember, I switch off my WhatsApp during working hours. So if you send a report, kindly call me up after that. Thank you.